Welcome to Peri-Op Academy, where we learn, care and excel in what we do. As previously promised in my previous video, I promised you that we're going to look at pulse oximetry and how it works. However, I want to inform you that this discussion is very brief and directed to the points which I think I want to share with you, and is looking at a patient as the patient is taken care of in the anesthetic room, in recovery, and back to the ward. However, this information can be clinically applied wherever the pulse oximeter is being used, be it in the ward, in the community, at home, wherever it is being used. The information you will receive here is equally the same. But in this case, I'm just thought of looking at it as we clinicians look after the patient in the anesthetic, recovery, and back in the ward. These are the scenarios I've considered. So, what is pulse oximetry? Pulse oximetry is a non-invasive method of estimating arterial oxygen saturation in the patient's, in the individual's body. What it measures the oxygenated hemoglobin, HbO2, and it also measures the deoxygenated hemoglobin, HHB. However, it does not directly measure the oxygen partial pressure, the oxygen delivery, ventilation, carbon dioxide, and tissue oxygenation. It doesn't directly measure those. And then for us to go along in this discussion, I've thought of going step by step, and at this moment we want to look at the transportation of oxygen from the atmosphere until it reaches the tissues where it is finally utilized. In this case, we have oxygen 21% in the atmosphere. We breathe it in through our respiratory system, and it reaches the functional unit in the lungs, which is the alveoli. In the alveoli, it diffuses across the alveolar capillary membrane and binds to hemoglobin. And as an illustration through this little diagram I've shown here, this little drawing. Sorry for my drawing, I'm not so good at it. We have got the alveoli there, and the alveoli sac with oxygen. In this case, just consider that I'm not looking at gaseous exchange per se. I'll just restrict my conversation on oxygen alone. And as the oxygen is the alveoli sac there, and then it permeates, it diffuses across the alveoli capillary membrane. The alveoli capillary membrane is that thin membrane which lies between the alveoli and the capillary, and that space, that's where it diffuses. It gets its way into the bloodstream. In this case, it gets into the red blood cells and bind on the end. From there, it then is transported through the capillary system to the different parts of the body, and then taken to different parts of the body for tissue metabolism. You remember the mitochondria in the cell physiology. This is where the functional unit of organ works in the process of oxygen, in issues of oxygenation. And then when the oxygen is utilized, the reverse processes take place, and the processes continue and continue and continue. Therefore, I want to inform you that the pulse oximeter per se, it assesses how much hemoglobin is carrying oxygen. The pulse oximeter assesses how much hemoglobin is carrying oxygen. That's the brief information I want to say about the pulse oximetry at this stage as we move on. So here, In step 2, we want to look at hemoglobin physiology. It's just a brief overview, but it's not exhaustive. Like I said, it's a very intense topic on its own. But I've just extracted the essentials which will make us able to discuss how the pulse oximeter works in this case. So each hemoglobin molecule contains 4 hemoglobin chains and 4 hem groups. So each hem group contains 1 iron atom, and each iron atom binds to 1 oxygen molecule, and therefore 1 hemoglobin molecule carries 4 oxygen molecules. And to further that information now, to feed it into step 3, we want to look at the blood as it is in its different compartments. We have the arterial blood, which is bright red and has got the capacity to carry an estimated amount of 95 to 100% saturation. However, it's not always reachable, the 100%, let's say 98. But for the purpose of this discussion, I've given it the full range. While the venous blood carries deoxygenated blood, which is dark red in color, and has an estimation of 70 to 75% oxygen saturation. However, because this is kind of mixed blood, the deoxygenated blood is not totally devoid of a bit of oxygen. It is there, but it is not compatible with life. So we want to see this scenario, these 2 types of blood presentation and how it relates to pulse oximetry. This is what we want to now see how it works. The behavior of these red blood cells, and oxygenated red blood cells and deoxygenated red blood cells in relation to pulse oximetry. With the pulse oximeter has 2 lights. It has got the red light and the infrared light. And when we switch it on, you only see the red light. The infrared light, you are not able to see it, but it is there. The oxygenated hemoglobin HbO2 absorbs more infrared light than the red light, and the deoxygenated hemoglobin HHB absorbs more red light than the infrared light. So this is the information which we would want to interrogate as we go forward. So we have the pulse oximeter, the gadget itself, we have the probe, and we have the monitor, including the mechanism on how it works. I would say the machine itself in total. So I'll switch it on. It gives us the beep, say it is on, and I'll show you the light as we go along. So we have the infrared light and the red light, but at the moment you can only see the red light, and at the bottom we have the receiver, the receiver of that light from the top as it being transmitted from the top down, as you will see shortly. And we apply the pulse oximeter probe, and the light from the top travels through the body tissues. Some of the light is absorbed by the tissues, by the bone, and reflected through the red blood cells, and then reaches the bottom end. And that information is then translated onto the monitor as figures and values. I'm 99% saturation, yoo-hoo! And I've got a heart rate of 91 simply because I'm a bit talking, and my PI percentage is 10.6. Oh, that's great. And the waveforms which you are seeing there mimics the ECG. It's actually like an ECG. The spike means the systolic and the depression means the diastolic, and those are the parameters in which you can see. As you can see, the waves are bouncing, meaning to say that the blood supply to the area is very rich. And this, as it works, the light as it travels through the tissues and the like, the bigger the blood vessel is, the more the distance the light travels, and the more the absorption it gets, and the more the accurate value of saturation you get. The smaller the blood vessel, the lesser the distance the light penetrates through, and the lesser the accuracy of the figures which you see on there. I just wanted you to let you know. It's a very interesting topic if you read through as in relation to these values and parameters. It's so interesting. So that's the information as it relates to the conversation which we are on today. Now we want to find out, why is it called the pulse oximeter? Why do we call it the pulse oximeter? We call it pulse oximeter because the pulse oximeter only works on detection of pulse. It works where there is pulsation. If there is no pulsation, the gadget is rendered irrelevant, and whatever information you get from there is not accurate. For that reason, that is why it is not a reliable gadget in cardiac arrest, because the heart is already stopped or is stopping or is struggling. We want to revive it, and the peripheral perfusion is not there, pulsation is not there, so this is not a reliable gadget to use it. In severe shock, we are not using it. Why? Simply because in shock, the periphery blood vessels are constricted and the blood is redirected to other parts of the body where blood is essentially needed. That is the gut, the lungs, the heart, the liver, and the brain. So in severe shock, we'll find that the use of the pulse oximeter can give you a limited results which are not as accurate as you want to see. And in severe hypotension, for the same reason, when you are we've got a patient or an individual is severely hypotensive, the saturation is not as reliable for the same issues which I discussed before: vasoconstriction, peripheral shutdown, and blood being redirected elsewhere. And in this case, we want now to look at factors which affect the accuracy of pulse oximetry. Like we indicated earlier on, hypotension, low blood pressure, the efficiency of this gadget in that situation is low, for the same fact that there is peripheral shutdown, the blood is being redirected elsewhere, and pulsation is minimized. Until we correct that, you can still get the values, but the accuracy is compromised in that situation. And with patients with artifacts, patients who have nail polish or artificial nails, the light has challenges in penetrating through those artificial gadgets or artificial artifacts. Therefore, patients who come into theatre would be required to take off the artificial nails and scrape off the nail varnish, maybe 2 or 3 fingers, to have access to those to a better perfused part of the body, in this case the finger. So we also have a lack of accuracy where there is carbon monoxide poisoning. What happens is that the carbon monoxide has got a high affinity of oxygen. It deprives the patient of that, and yet on the screen it will mimic as if the patient is well perfused, well oxygenated. And in this case, we undertreat the patient with these results. So patients with carbon monoxide poisoning, bear in mind whatever values you are seeing on there, they may not be accurate because of the behavior of the carbon monoxide's relationship with oxygen. And we also find in methahemoglobinemia, we also have a situation where there is a mimicking of less oxygenation. In this case, it will be about 85 and below. And in this case, we may over-treat the patient, thinking the patient is hypoxic, and we do otherwise when the patient is already quite okay. And then finally, we want to see the clinical implications in anesthetics and recovery. Any specialist, any clinician who works in this environment, in theatre, in anesthetics and recovery, have to have a knowledge or assume to understand better how this gadget works, because understanding this gadget and how it works, this pulse oximeter and how it works, it helps us to take action in order to minimize the issue of hypoxemia early. Once you understand this is a very invaluable gadget where it is needed almost all the time to make sure that the patient is well attended to, is well oxygenated, and we can translate the values which we are seeing on the screen to the actual clinical patient and take action accordingly. So, in interpretation of this gadget in theatre, we also have to consider the following: the airway patency. We ensure that the patient's airway remains as patent as possible for the purpose of good maintenance of oxygenation. Any issues which interferes with airway patents must be addressed. If you are in recovery and you are working and you see any chances of you having issues with the airway, don't be too brave. Highlight it, and the relevant people can come and give you a hand. Only if you have got the clinical understanding of why this is happening, so that's it. But if you've got any doubt, don't be brave. Just call and the help is there, and your anxiety is relieved. And as we are looking after the patient, either way in theatre and recovery, we also want to assess the respiratory rate and pattern. The greater the tidal volume the patient creates, the better the oxygenation results are, and the better the values of that oxygenation is translated on our pulse oximeter. So we check on the respiratory effort, especially in recovery. How is the patient's respiratory pattern is? Is it shallow? Why is it shallow? How can I make the patient alert? Do I need to adjust the patient's position? Do I need to make sure what are the issues with that respiratory pattern. Is it fast, irregular, or whichever way you look at it, make sure these issues are addressed. That is a very important clinical decision you can ever make in this capacity. And then the issue of capnography. When the patient comes to recovery, usually if they have an air adjunct like an LMA, not an ET tube, unless they're going to ITU or HDU for further ventilation, normally when they come to recovery, they would have an LMA. And when they have an LMA, you've got a very good, accurate measurement of how the patient is breathing through the oscillation of that white line you see, and shows you how patterned the airway is. And those same values will be translated on the screen for you to evaluate the oxygenation of this particular patient. When the patient has got the Hudson mask, or the simple mask as we want to call it, we still have an attachment for capnography. However, that is just a simple measure to see that the patient is breathing. It doesn't give us the actual values as compared to the LMA or iGel or whatever adjunct which you have in there. It shows that the patient is breathing adequately, but the accuracy of the depth of understanding of the CO2 concentrations, they are not as good. But as long as you are happy with your values, that's even good enough. And then the rest, the heart rate and blood pressure. The low blood pressure you get, the chances of you having low oxygen saturation are likely, for the same reasons we discussed before, that of vasoconstriction, vascular collapse, and blood being rediverted elsewhere. If it is vasoconstriction because of temperature, we want to know why the patient has hypothermia. We address it by warming up the patient, by making sure the patient is fairly comfortable for us to get the good results. And also assessment on the skin color and perfusion. Have a constant look. Understand how the patient's skin color is. The patient is pink, warm, perfused, good. If there is any challenges in you understanding the light, Asian gray, the patient is blue, or something like that, you have to have a quick assessment and understand the parameters as it relates to ECG, as it relates to pulse oximetry. And by the way, we are not nursing the gadget, we are nursing the patient. The gadget is there just to give us a brief overview, but our eyes are focused on the issue of patient safety, aided by the gadget which we have. And also in recovery, and as well in anesthetics, if the patient has got sedation or things like this, the level of consciousness, if the patient is not as conscious, their breathing is shallow, hence their ability to create a big tidal volume is there, and the chances of oxygen levels falling down, desaturation happening, are most likely. We need to address those things, rouse the patient if need be, to just make sure that they are breathing. You are not interfering with their quietness and everything, but you want to have a sound patient who is okay. Lastly, the effects of anesthetic drugs and opioids as they are being looked after in theater and recovery, you also has an implication on the pulse oximetry evaluation. So understand the drugs which have been used in there, which tend to reduce the respiratory effort, which tend to reduce the blood pressure, which tend to reduce the heart rate and things like this. As long as you know these issues, you are effectively applying your skills and knowledge in relation to pulse oximetry and how it works. So, and one last point which I wanted also to highlight on these factors which limit the accuracy of pulse oximeter is, for example, issues of if the patient is restless, and the pulse oximeter doesn't work so well. So make sure the patient is calm, comforted, and you tend to get the results right as we go along. However, as we said before, you are not nursing the gadget, you are looking at the clinical picture. How is the skin condition, respiratory effort, and all these things before you jump. One jumps to make a conclusion, say the patient is hypoperfused, therefore that could be the issue, but just bear that in mind. Anyway, it was a long video. Thank you for your patience and attention, and we got this far. And like we say in Peri-Op Academy, we continue to learn, care, and excel in what we do. Hope this information is good for our clinical practice together. Until next time, bye-bye and God bless you.